So what is blood pressure? Blood pressure is, simply speaking, pressure of blood in the arteries, and normally it's denoted by two numbers. You have a numerator called systolic blood pressure, and then you have diastolic blood pressure. The systolic blood pressure basically informs us of the rate at which, or rather the volume of blood being ejected by the heart, and the diastolic blood pressure essentially tells us how the resistance offered to this blood flow in the small vessels in the body. We've been measuring blood pressure for a long time, since the 17th century, and as you can see, the sophistication of the devices increased over time, and now the most commonly used devices are these electronic blood pressure monitors. And we also have ambulatory blood pressure monitors, wrist monitors, and various other devices. All these are to increase the precision of blood pressure measurement and to ensure that we have the right value for the patient. But what is blood pressure? People have been noticing that blood pressure, there is a value to blood pressure, there is a level of pressure of blood within the arteries. But the earliest data on blood pressure distribution in the population came actually from the insurance people. This is the Society of Actuaries in 1925 in the US. They simply measured blood pressure in people. Obviously, their intention was to try and maximize their profits, either by denying insurance or actually trying to identify the markers which would predict people dying early. So as part of this, they just measured blood pressure, and they noticed, interestingly, that blood pressure there was a distribution. It was not that everybody had one blood pressure. There was a distribution from low to high, with most of the blood pressure essentially around the between 120 and 140. So this was interesting. So there was no explanation for this, but people accepted, yes, blood pressure tends to vary quite considerably across the population. The actuaries also noticed that there was, and they were the first people to notice, that blood pressure increased with age. With increasing age, you have increasing blood pressure. They also noticed with increasing weight or body mass index, your blood pressure increased. And this is our current understanding of blood pressure. We know that systolic blood pressure, the top reading, increases linearly with age. Diastolic blood pressure increases up to around age of 50, and then it plateaus. So our understanding of blood pressure slowly increased. We knew that there was a distribution, a normal distribution of blood pressure. We knew an age and BMI related difference in blood pressure. However, the understanding was that this blood pressure is reactive. It's not disease. People noticed that high blood pressure was associated with people who had slightly thickened arteries. So they felt that blood pressure was essential to drive, increased pressure was essential to drive blood through the arteries. And hence the term essential hypertension. It's not a disease. Your high blood pressure was essential for maintaining your blood flow. In 1912, a famous clinician, William Osler, came to Glasgow. He presented at the Glasgow Southern Medical Society. And his advice was that high blood pressure is not the primary feature, and it's not a feature to treat. And this was his advice, and this was the general medical understanding of blood pressure. Do not interfere with blood pressure, it's important for you. Liverpool, in 1931, the greatest danger to man with high blood pressure lies in its discovery, because some fool will try and reduce it. So going back to the actuaries, they looked at mortality because they're interested in people dying. They looked at mortality, and they noticed that with increasing blood pressure, so this is the graph showing the ratio of expected deaths to actual deaths in different groups of people with different blood pressures. And they noticed quite nicely that if your blood pressure increases, there's a significant increase in deaths. And obviously, you need to understand that this is data from a selected population. These are generally this population was between 38 and 42 years old. There were people who are insured, so this doesn't include people who are not insured, or people who did not seek insurance. But even so, you could see a nice linear relationship between blood pressure and mortality. With high systolic and diastolic blood pressure, you almost have 400-fold increase in deaths in those groups. So this was worrying. But the question still remained, do we reduce blood pressure? Even in the early 1900s, some of the treatment for blood pressure included bloodletting and infecting people with pyrogens like typhoid. But the medical understanding was, that you do not treat blood pressure. But people were coming around to terms with the fact that blood pressure may kill people. People were unable to define at what threshold should you start worrying. In the 1940s, they thought, well, up to 200 by 100 millimeters of mercury should be considered mild hypertension and do not treat. Or perhaps you should have other symptoms like chest pain or coronary disease. Only then should you start treating blood pressure. These were the New York nihilists. They said people with hypertension are psychotic. Around this time in 1948, the Framingham Heart Study. So what was needed was a large general population study, an unselected general population study, population who could be followed up with blood pressure, prospectively followed up with blood pressure measured, and see whether there was a difference in outcomes. So the Framingham Heart Study started recruiting in 1948, and very early on they noticed there was a relationship between people with high blood pressure and stroke, heart failure, and kidney damage. Slowly, we've got more and more evidence accumulating, relating from general population studies, prospectively followed up, relating high blood pressure to increased risk. And this is from the Enhance study, which show increased cardiovascular deaths with increasing blood pressure, almost similar to what the actuaries showed in 1925. So the question is, if you want to treat blood pressure, you need to have a threshold. You need to define a level at which you would say that that is dangerous. And it was very difficult to define that threshold. Is it a blood pressure level that increases cardiovascular risk? This is the definition by Rose, who said that's a threshold at which the benefits of action should exceed those of inaction. So again, a bit woolly. There's no defined criteria, but it depends on your personal view. And obviously, what's lacking here is evidence. You needed hard evidence that at a particular level, risk increases. As I mentioned, in 1940s, people thought 200 was normal. We've slowly brought that down. Now it's sitting at 140. And this is the 5-year risk of myocardial infarction and stroke. And you can see from 140, there is a steep increase in risk, but there's also increase right from 100 onwards. So we take 140 as the threshold to start treatment. And what happens if you have a high blood pressure greater than 140? What we know in the population is this level of blood pressure is associated with 69% of all first MIs, 74% of coronary heart disease, 77% of first strokes, and 91% of heart failure. So that's the risk we would like to reduce. To complicate things further, Pickering, one of the experts in blood pressure research in 1968, he said there is a problem here. Blood pressure is a continuous quantity, meaning you can't define, you can't have an artificial division saying that at this point it's hypertension and if you have a blood pressure lower than that, it's normal. He said the dividing line is artificial, there is a continuous risk. This was in 1968. He said there's a continuous risk in blood pressure for every point increase in blood pressure. We had to wait till 2002 for the definitive answer to that. This is a 1 million-person study. During this time, there were lots of trials going on, blood pressure lowering treatment. So the blood pressure trialists collaboration, they amalgamated all these studies and showed, and this equated to about 1 million people. So the follow-up data from 1 million people showed that you have a linear increase in mortality with increasing blood pressure. And that didn't start at 140. It went on down to 115 millimeters of mercury systolic. So you had a linear increase at every age. Obviously, if you grow older, you have a higher risk of dying. So you see parallel lines, but each lines are parallel to each other, and there's a linear increase in both stroke and ischemic heart disease mortality. The NICE and the current NICE and British Hypertension Society guidelines have defined these thresholds as the threshold at which you intervene with drugs. That's for office or clinic blood pressure, you take 140 by 90, but you can do slightly lower blood pressure thresholds for home or ambulatory blood pressure monitoring. And ambulatory blood pressure monitoring is blood pressure we measure repeatedly over 24 hours. And so we know that there is now evidence that if you have high blood pressure, it's associated with increased risk. But is there any evidence that if you reduce blood pressure, you reduce risk? Because that's the crucial point. That's causality. We need to link that it's blood pressure which is causing the increased mortality and not something else. Blood pressure is not a bystander. And again, going back to the million-person analysis, so this is quite a large study, and this showed that even a small drop in blood pressure can be associated with significant reductions in mortality, both stroke and ischemic heart disease. So a 2 millimeter drop in systolic blood pressure can lead to a 7% drop in ischemic heart disease and a 10% drop in stroke mortality. So in a sense, you can link all this together. There has been a lot of clinical trials wherein they have shown reducing blood pressure does improve outcomes. What we see from this study is even very small changes in blood pressure will improve outcomes. Stassen and others amalgamated all these studies, and they did some fancy analysis to show. Now, as you know, all clinical trials are devised to test the efficacy of one drug against another or against a placebo, and most of them are funded by pharmaceutical companies to show efficacy or effectiveness of their drug. But when you combine all those, what you see from this slide is what matters is not the drug you use, it's the amount of blood pressure reduction. The more blood pressure reduction that's achieved in the trial, the better your outcomes. So it doesn't matter which drug you use, as long as you can get blood pressure down, then you improve survival. And it's cheaper than doing nothing, according to NICE. In terms, so that's about blood pressure. What happens globally? Globally, it's a major problem. Over 1 billion people have high blood pressure worldwide, and that's going to increase to 1.5 billion by 2020. So it is a major public. If you align this with the risk associated with blood pressure, it's a major public health problem. The WHO Global Burden of Disease Survey showed that among all the risk factors, the risk factor which is associated with the highest burden of mortality is high blood pressure. It's not, I mean, you may see all the other common risk factors, but the greatest predictor of mortality is high blood pressure. What about UK? Recently, you had the UK version of the Global Burden of Disease Survey, and this looked not at mortality, but it looked at disability and health burden on the population. And here again, high blood pressure is a second only to tobacco smoking. So this is a major public health problem that needs to be addressed. And this harks back to the usual definition of hypertension as a silent killer. Most of this problem is because blood pressure is not diagnosed early, not treated early. In Scotland, we have about 1.5 million people with high blood pressure. About 250,000 men and women attended a general practitioner for blood pressure related problems at some point in 2010. 22% of all mortality in Scotland can be attributed to non-optimal blood pressure control. So 100 years after William Osler published in the BMJ, Tom published in the BMJ in 2012, just highlighting certain issues with current guidance. We have come a long way in terms of evidence and management protocols for blood pressure, but there's still a lot of work to be done to sort this out. In view of this, we have actually formed a collaboration. We hope to develop we have been discussing over the last 8 months to develop a Scotland-wide collaboration, and these are all the 4 main centers in Scotland come together. We work together to try and develop a system similar to the system for diabetes to help reduce the burden associated with high blood pressure. And more radically, the American Heart Association now thinks we need to act even earlier. They believe, at the moment, we wait for somebody to either develop an event or develop a risk factor, meaning only when they get high blood pressure do we intervene and start treating. The AHA's radical plan is essentially to go towards primordial prevention, meaning you start preventive management even before the risk factor emerges. But that's a long way away. I'll stop here, and thank you.